SICS platforms, 2 sessions are every time given by AIOS, and this ISM SICS gives the platform for SICS innovation, research and postgraduate teaching. So I request the convener Dr. Purvi Bhagat and Prakash Marathe to join on the stage. Chairperson Dr. Jagannath Boramani, Co-chairperson Parikshit Gopte, Satanshu Mathur, please join us on the stage. I request the discussants of this session, Purendra Basin, Rajvinder Kaur, Dr. Kimaya Chauhan and Dr. Jennifer, please come on the front place. We have very experienced discussants with us. We are going to have a very interesting session, Magic of SICS. So with this, I request our first speaker, Dr. Jagannath Boramani, to give a short introduction.
Yes, tomorrow again we have got another session. ISM SICS is International Society of Manual Small Incision Cataract Surgeons. This was formed in 2005 by the founder chairman Dr. Amulya Sahu with help of myself, Dr. Jagannath Boramani. Now we have almost 21 years of presence, and this society has almost grown like a big tree. Long back, about 20 years back, everyone was feeling ashamed that he is doing SICS surgery because this was supposed to be considered as an inferior surgery. So most of the surgeons were proud in talking about the fact, I am having this machine, that machine. That's why Dr. Sahu felt that this is an state-of-art surgery. Most of the surgeons are in India, and the world should know about this surgery, how we can give results. So throughout these 2 sessions, you will be seeing a lot of videos, and especially what are the recent advances in SICS and how it can be promoted, and it's a premium surgery. No doubt one can learn all types of techniques, but should not consider SICS as an inferior technique, because maybe market has played a major role in promoting the machine surgery as a main surgery. It's not like so. So we'll come to know through both the sessions. So instead of I talking about the organization, our first speaker is taking us through the journey of our organization. So may I invite Dr. Usha Johari to show the video of milestones in the journey of ISM SICS.
A very good afternoon to all of you. I am Dr. Usha Johari, and it's my proud privilege to present this video where ISMSS has gone all over the world, and we are having more and more planning to have more and more international places where we could showcase the excellent and the brilliant work which Dr. Amulya Sahu and Dr. Boramani have done in the past since 22 years. So over to just play the video. And thank you for giving me this opportunity.
Small tunnel incision is a secure incision. There are newer advances in MSICS, like 2 mm SICS surgery, smart incision surgery, and customized incision cataract surgery. The International Society of Manual Small Incision Cataract Surgeons was launched in 2005 by Dr. Amulya Sahu, the founder chairman, and by Dr. Jagannath Boramani, the present executive chairman. Immediately after the formation, ISMSICS started organizing many international events. ISMSICS was invited to conduct a web lab in APACRS in 2015. In 2018, in WOC, ISMSICS conducted a session in a wet lab. The Master's Guideline ebook was launched during this conference. In 2022, the ESO invited ISMSICS to conduct a 2-day workshop in Dubai. In the same year, the organization conducted a session in Mexico. In 2023, the annual conference of Emirates Society of Ophthalmology, ESO 2023, ISMSICS was given a session, a workshop, and a wet lab. In the same year, ISMSICS conducted a session and performed live surgery in Moscow. In ESO 2024 again, ISMSICS conducted a session, a workshop, and a wet lab. APAO 2024 offered 2 wet labs to ISMSICS. In November 2024, ISMSICS was invited to conduct a 5-hour symposium and wet lab by the European Society of International Ophthalmology. In 2024, as well as 2025, in coordination with REMSCO and APAO, ISMSICS conducted live surgical workshops, wet labs, and CME programs in Kelowna, Fiji. In 2025, a workshop was conducted in Sydney, Australia. In India, ISMSICS has regularly been invited to various CPD programs, state conferences, and to participate in AIOC, the largest conference in India. ISMSICS started holding world conferences every 2 years, from 2015 onwards. CCC stands for Comprehensive Cataract Conference. Our past partners for these conferences were Arvind Eye Care System, Disha Eye Institutes, PGI Chandigarh, LV Prasad Eye Institute, and AIMS New Delhi. From 2024 onwards, ISMSICS started conducting biennial zonal conferences in India. In 2017, ISMSICS became a partner of Help Me See for training on simulator. ISMSICS has chapters in almost all states of India and in 24 countries across the globe. These are few images of online, as well as physical launching of chapters in various countries. ISMSICS has conducted more than 80 online webinars. The organization has a women's wing also. The online Global SICS training program was inaugurated in 2022. Though ISMSICS had published many journals in the past, from 2021 onwards, it started regularly publishing the peer-reviewed journal, which has been now indexed with Embase and MCare. This is our website. Scan this QR code to become a life member.
Thank you very much. And this is the only society in our country, which has such a worldwide recognition. So, help us to grow more. We would like to have more and more members, not only from India, but from all over the world. Thank you very much.
Thank you, Dr. Usha ma'am, for that extensive journey of ISM SICS through video. Now I call upon our next speaker, Dr. Ravi Trehan, to speak on embryological consideration in MSICS.
Good afternoon. First of all, I'd like to thank team ISM6 for giving me opportunity to speak on this topic. A number of techniques are coming, SICS, M6, Smart SICS, FECO, FEMTO. But what I think practical knowledge of embryology really adds in each and every technique. So I just want to share few of my experiences. Understanding embryological origin of ocular structures is crucial in M6. It adds in recognizing tissue properties, surgical risk, healing responses, ensuring safe procedures and better outcomes. And this presentation will highlight developmental basis of key eye components relevant to all surgical techniques. Surface ectoderm, neural ectoderm, mesoderm, these are the main. So from surface ectoderm, this gives rise to lens, corneal epithelium, cornea as well as conjunctival epithelium. And we all know these can regenerate. Corneal epithelium regenerating, conjunctival regenerating, and lens epithelium also keep on regenerating because it is came from surface ectoderm. Notably, lens capsule elasticity, especially anterior capsule, is critical for CCC. Lens epithelial cell proliferation explain formation of after cataract or PCO, impacting post-op outcomes. Then neural ectoderm forms retina, optic nerve, iris muscles and ciliary epithelium. Iris muscles are delicate, vulnerable to trauma during surgery, this necessitating careful nucleus delivery. Retina's poor regenerative capacity underscores importance of preventing vitreous loss to avoid severe complications. The neural crest or mesoderm, corneal stroma, endothelium, trabecular meshwork, scleral and iris stroma. These structures exhibit unique healing and regenerative properties critical for surgical planning. Mesoderm contributes to extraocular muscles, vascular endothelium, this influencing bleeding risks during surgery. Understanding these origin helps prevent complications and ensure tissue preservation during M6. Anatomical planes we see during scleral tunnel we are making in SICS and FECO as well. So this is the typical structure that helps all of us to make scleral tunnels. The corneoscleral junction, that is a blend of ectodermal and neural crest rich in stem cells and vasculature. Precise incision placement here minimize endothelial damage and protect the limbal stem cells also. 3 layers conjunctiva, then tenon and then sclera. During M6, when we are going for conjunctival flap and then we cut tenons also, and in end generally sometimes tenon is not reposited, that receded back. So direct apposition of two sclera and conjunctiva, fibroblast will appear, and these fibroblast is the causes of unexplained irritation in the eye. But we see each and everything is okay, eye is white, but irritation is there. Most of the patients we generally observe in our OPD, that is because of this region. If you reposit the tenon and then put the conjunctiva, that certainly will be helpful. Then lens zonules. Lens zonules develop from neural ectoderm, ciliary body, essential for lens stability. Congenital or developmental weakening zonule raises risk of zonular dialysis during nucleus prolapse in M6. Recognizing these risks allows surgeons to tailor techniques and safeguard against intraoperative complications. Now I'd like to say one word about lens sutures. As we all know, it is inverted Y shape. if we plan division of our nucleus at 12 o'clock, generally what we feel, even in hardest of the nucleus, a very good cleavage is there that helps in dividing all the nucleus. And regarding IA, again these sutures, 4, 8 and 12. At these sites, adhesions, cortico-nuclear adhesions, corticocapsular adhesions are more strong. So to start with, if we detach those adhesions during IA from 4, 8 and 12, rest of the cortex material epinucleus will come out very easily. Key complications like PC rupture, corneal edema, iris prolapse, vitreous loss related to embryological tissue regions, and a non-regenerative corneal endothelium from neural crest, delicate iris muscles from neural ectoderm necessitates meticulous handling. These insights are crucial for practical surgical applications. Now, understanding the embryological origins of eye enhance M6 safety and efficacy. Knowledge of tissue development guide surgical technique, minimize complications and supports wound healing. This foundation is indispensable for clinical practice. Thank you.
Thank you, sir, for brilliantly highlighting the correlation between the embryology anatomy and the surgical anatomy. It definitely makes a difference in the way we operate and the visual outcomes. So now we invite Dr. Anil Kothari is here for his talk on wound construction in manual SICS.
Good afternoon, everybody. I'm thankful to AIOC SICS Society and especially Dr. Ravitra to just give me a chance to speak here. I'll speak on wound construction in SICS. Wound construction in manual small incision cataract surgery is very critical because all complete result of the surgery, it depends upon this. It should be self-sealing, it should be watertight, sutureless and astigmatically neutral outcome. Basically, the small is what I think is a misnomer because smaller is bigger than smaller. Small is still bigger than smaller. So it should be called adequate incision surgery. To be planned depending on hardness of the nucleus, amount of astigmatism and condition of endothelium. The key aspects of MSCI's wound construction is incision site and shape. The straight or front incision is made about 2 mm or 3 mm posterior to the limbus for better sealing. The tunnel architecture is very important. The tunnel should be strapped or funnel shaped structure. Funnel is what is that? Two curvilinear lines, imaginary lines on the sclera, which is very narrow at the limbus and wide as you go posteriorly. So in this particular funnel, you make incision at any site, maybe nearer to the limbus or away from the limbus, the astigmatism will be the same. So narrow on the sclera and wider inside the anterior chamber. Astigmatism is inversely proportional to the distance of incision from the limbus. As you go posteriorly, in the astigmatism will be very less. The depth, the half thickness of the sclera, say about 0.3 mm scleral incision is maintained throughout. The premature entry, sometimes it causes iris prolapse and too shallow incision leads to a buttonhole. So one should be very careful to maintain the thickness of the sclera while making dissection. The width should be what I told, small is a accommodative surgery or it is as per needed. The incision size is 6 to 7 mm in cortical cataracts and 7 to 8 mm in hard 4+ nucleus sclerosis cataracts. And in case with low endothelial cell count also, the incision should be proper or very comfortable, so to give very less damage to the endothelium. Procedural step is conjunctival dissection. Peritomy is performed 3 mm behind the limbus to expose the sclera. Scleral incision groove, a 5 to 6 mm curvilinear front incision is made, which is 0.3 mm deep. Scleral tunnel dissection a crescent knife is used to dissect forward movements towards the cornea. The blade should be parallel to the scleral plane. And as you go, once you start dissecting in the sclera and once you approach the cornea, the knife should be in plane with the cornea. The entrance into the anterior chamber, as a keratome is used, 3.2 millimeter keratome is used to enter the anterior chamber. Once is dissection in 1 to 2 millimeter. The tunnel should be at least about 2 millimeter in the cornea, in the clear cornea. The tunnel expansion, the incision is widened internally to form a funnel shaft. While making a decision, while making a wound, one should make the pockets in the side. Once at the end of the incision, one should make the pocket, scleral pocket, or it going up to the cornea. Side port, a small port, 15-degree blade is created for manipulating the lens, usually at 9 or 3 o'clock. Be cautious not to damage the anterior capsule or corneal endothelium. The common pitfalls, usually buttonholing, superficial dissection causes while making a tunnel, the dissection should be at one plane. If you make a hole in the scleral flap and fixed by moving a deeper, then you have to leave that one and start at the other place, at a more posterior place or a slightly more deeper. Premature entry, the knife enters the anterior chamber too early, then results in iris prolapse or poor sealing. Iris prolapse hyphema controlled by the proper depth and securing hemostasis while cautery. And if the incision is anterior, it will cause poor sealing effect, wound leak, ATR astigmatism. Then the management is only to put the sutures. One should not feel shy by applying suture in such cases. If the incision is posterior, the risk of bleeding, premature entry, and difficulty in instrumentations. If sometimes the pre-existing against the rule astigmatism there, presence of superior filtering drape in case of glaucoma cases, secondary procedures, if it is a secondary procedure, previous surgical scar in aphakic eyes, intraocular lens exchange, extremely deep sockets, the temporal approach to scleral tunnel is very good and very easy to perform the surgery. The advantages of a temporal tunnel is where the against the rule astigmatism predominantly exists, it should be preferred, better working space, and the red glow is better appreciated. Now a small video. Make a conjunctival incision, cautery is done, and a Fran incision is made with the Bart Parker knife, and the dissection is made. First in the sclera by sweeping movement, first on the front and then on the side sweeping movement, slowly and slowly, both the sides, and pockets are made on both the sides to facilitate the delivery of the nucleus. Anterior chamber is reached, and after hydrodissection, I just usually put a slide made of that IOL foliage and the easy delivery of the lens. Thank you very much.
Thank you, Dr. Anil Kothari, for that excellent wound construction in MSICS. So what is main important in wound construction, which is the art and soul of the SICS surgery, the depth of the incision throughout, it should be uniform. So we would like to take 1 or 2 lines from our expert panel on MSI's wound construction. Dr. Kimea.
Good
Good afternoon, everyone. Yeah, so the depth of scleral groove generally we say 0.3, but the student should always see that the patient is normal height. Suppose he has hypermetropia or myopia, the depth changes. So it's not uniformly 0.3. If it's hypermetropic, you have to go a little bit more deep, and myopia got to be more superficial. So there is one more thing which I want to give. And when we train students, we always say the major complication are premature entry and buttonhole, as said by the previous speaker. So basically that you have to see that the way you are going to go with your crescent, the heel and the tip should be, properly oriented. Okay, because if you are having the tip which is going downwards, you are going to have premature entry in every case. So you have to be very parallel to the sclera and then proceed. And always we have seen that when you complete the tunnel, the central first, then the chances of getting complication are lesser than if you complete, just go on towards side first and then go to the cornea. So first have that thing first, so go from the sclera in the center, complete that particular 3 mm or 4 mm incision first, and then go to the lateral sides. That will be better.
Thanks.
To have less complications. Yeah.
Thanks, Dr. Kimaya, for that good learning pearl. Now, next we move on to next topic, that is management of capsule in MSICS. I request Dr. Rajesh Goyal.
Good afternoon, everybody. I am thankful to the society for providing me this opportunity. ECC, that is extracapsular cataract extraction. Management of capsule basically involves making a capsulotomy, that is making an opening in the entire capsule so that nucleus can be delivered, maintaining the safe removal of the nucleus, and if any complication arises, we have to manage those complications. Now there are multiple advantages of SICS. We all know it's a short operative time, low cost, and less need of technology. Need of topical anesthesia, local anesthesia depends on the surgeon. Now instruments which use basically is a needle, 26 gauge needle, or we may also use a forceps, that is capsule access forceps. Now capsule openings may be either CCC, that is continuous columnar capsule access, can opener, or the envelope type. So what is CCC? That is, we have to make adequate size opening. It should be adequate so that the delivery should be good. It should be at least 5 to 6 mm in size. The movement while doing the capsule access should be shearing force. That is, it should be tangential along the line of the force. It should not be towards the centripetal. That is towards the center of the circle. Okay, so that's how we complete this CCC. That is continuous columnar capsule access. It is very good because we can easily clear the cortex. There is stable IOL and there is safe hydrodissection. But if we make a small CCC, then we have to convert it into we have to make can opener openings in that. Okay. Now comes the can opener technique. That is, we are making the punctures in the capsule with the help of the needle. Thereby, we are making many radial tears, and it's very good in case of brown or black cataracts. It is good because it's easy to learn, but it's bad because we may damage the capsule. Now comes the envelope technique, in which we make a linear incision and then we take out the lens. Now it's a small video. Okay, it's a small Before doing the surgery, we were not aware that there is a zonal dialysis because the people was not dilating fully. When we placed the viscoelastic, then we found there was zonal dialysis, as you will also notice, between 12 to 3 o'clock position, and there is pterygium also. So what we do is, we scraped it away. That is very adequately filled up. Then only we proceed for the access. When I am doing this, then I yes. excision. Slowly going. So that complete the axis after making the tunnel. So after this, I have stopped the axis here. And make a large size, like 6 mm sized axis. Because my rexes were adequate, I was able to out of this capsule very easily. It came out so easily because the wound was. While doing the vertical cleaning, and then I clean from the here is I had placed the haptics along. So this haptic will act as a CTR. It's a pharma oil. And because shoulder is over there, although the thank you.
Thank you, Dr. Rajesh, for that nice video demonstration. And indeed, like especially with the beginners, I'm sure Dr. Kemaya must also agree that the PGs are always in great fondness for doing a rexis. They always want to start doing a rexis from the very beginning. So they should understand that a poorly done rexis should be avoided, and rather a nicely performed can opener would always be better. So don't like always fancy doing a CCC. So any tips, Dr. Parikshit, on capsular management, or and what would be the role of radial extensions or tears that we make for nucleus delivery in MSICS?
As you said, a good can opener is also suffices, but unfortunately can opener has got a bad name nowadays because everyone wants to do a CCC because that's perfect. And in today's time, everyone wants to do the perfect thing only. What is slightly below perfect is not considered that good enough. But that's not the case. But two things, one which I liked about it is you put a suture at the end. So what is more important is to have a good self-sealing incision. So putting a suture is again not something that is imperfect or less than perfect. And for the previous one, like what Dr. Kemaya was telling, is about the plane of the incision. And also equally important is the site of the incision. So a lot of the customized incision cataract surgery that Dr. Boramani has been propounding. So it's the site of the incision also that is extremely important. So perhaps not for learners or beginners, but once people become experienced surgeons, that is another great, what shall we say, advantage of SICS, is that we can actually manage the astigmatism.
What
Just
would be the
one
role
point,
of radial
okay.
cuts?
Yeah, that's what I just wanted to add one thing, that even if it is a beginner surgery, whenever you are to convert, and if your CCC is getting smaller, first try and make a tangential cut. Don't immediately go and make a radial cut because that will go to periphery when in hardly few minutes or seconds. So always try to have radial cut, okay, with venas, and then try to take a flap with the McPherson fossa, with a capsular fossa, and then try to make it CCC. If it's not possible, last resort is your radial cuts. Now we are not promoting radial cuts anymore. And yeah, please go ahead.
No, please.
And as he was telling different types of capsulotomies, there are certain cataracts where your envelope techniques work the best in case of Morganian cataracts and in case of grade 4 cataracts, where even the capsule is very fragile, so it's difficult to make CCC and can opener as well. Their envelope techniques work the best. Even Morganian cataracts where you have all liquid, around. So just make a nick, then make an envelope, and then take the cataract out. And maybe you can even have just give a wash and give the IOL place in the bag with the anterior capsule on first. And when the IOL is in the bag, you can take the support of IOL and then get the capsule out, anterior capsule. So you have shown that the IOL is in the bag in case of monofocal cataract. So actually choose your type of cataract depending on cataract, what you have, what type of cataract. Okay? Yeah.
This case has a region. We have made a side port and a side button. I think it is better to make.
Yes, yeah, because bleeding chances are more when you make at the same point. So always, when after pterygium you take out the same site you made, right?
Irritation is more.
Yes, and even the bleeding can occur if it's not fully taken out. So always opposite side will be better in such cases.
Next.
Thank you. So now,
I want to add one thing.
Yeah.
yes, sir.
The main complication of Rexis is runaway. And I just want to explain the mechanism of runaway and how to prevent it. Basically, each and everywhere it is written that we have to keep the anterior chamber deep. Why it is deep? Jonular attachment is such, posterior coming anterior and anterior coming posterior. So when AC is at normal depth,
Sir, please.
then jonules are at ease. But if it is shallow, then jonules pulling the capsule. And at that time, if we try to complete the rexis, likely to go away. So what we have to do, generally we are doing rexis in X and Y axis. As soon as you feel that this is going out, deepen the AC, and rather than working on XY axis, try to incorporate Z axis, pull the runaway part with forceps, and direction should not be this, direction should be adjacent opposite, because jonules are like this, and against exactly opposite, this certainly will act in a better way. So that is the point.
Thank you, sir, for those tips. We move on to the next presentation. I would invite Dr. Akshat Jain for his presentation on various techniques of nucleus delivery and manual SICS.
So a very warm good afternoon. At the outset, I would like to thank Scientific Committee and International Society of MSICS for providing me the opportunity to present on various techniques of nucleus delivery. So like most of the ophthalmologists of my generation, including me, are often captivated by the elegance of eco-emulsification. But it is essential to understand that SICS is the mother surgery of cataract care, especially in the resource-limited settings. So I would like to thank these esteemed surgeons and medical educators whose work have greatly helped me in the understanding of the topic and the procedures that I would be displaying. These are the abbreviations that I would be using in my presentation. So I would be broadly discussing these 6 methods of nucleus delivery. The first is the visco expression. Personally, it is my go-to method of nucleus delivery. So as once the nucleus is prolapsed into the anterior chamber and AC is nicely filled with visco, so with the non-dominant hand the bridal suture is tightened, and with the dominant hand the curved visco cannula is taken in. It is placed above the iris and lens delivers nicely. So the single most important factor for this method to succeed is the adequacy of sclerocorneal tunnel, and why it is a preferred choice is because it has the shorter learning curve, it is less traumatic to endothelium, and if the visco cannula is placed properly and AC is maintained nicely, there are very fewer chances of PCR. So this is the second technique, Vectis technique, very widely used. Uses this instrument irrigating Vectis that has 2 surfaces. Anterior surface is concave with 3 ports, and it is essential to check the patency of these ports before doing this technique. So it uses combination of both mechanical and hydrostatic force. So again, the visco needs to be nicely present both anterior and posterior to nucleus to coat endothelium and push iris diaphragm and PC backward. Bridal suture is tightened. Irrigation is started once the superior pole of nucleus reaches the tunnel and should reduced when maximum width of tunnel has come out to prevent the forceful expression of nucleus and sudden collapse of AC. So this is the another video of Vectis. Also, it is important to see the distal end of the Vectis to prevent the inferior iridodialysis. So the advantages of this technique is that only single instrument is used, unlike the other technique that we would be subsequently discussing, which uses two instruments. AC remains formed, and it is good for smaller tunnel and harder cataracts. Also, if there is diffuse zonular weakness or sometimes nucleus tends to become vertical due to PCR, so Vectis can be used as a rescue instrument in all those cases. The potential complication can be iridodialysis, mostly inferior iridodialysis if distal end is not seen properly and the Vectis gets hold of iris. Also, if the visco is not filled properly, it can cause endothelial damage and posterior capsular tear. This is the third technique, the phaco sandwich technique. In this, the nucleus is sandwiched between the Sinsky hook above and Vectis below. So, sorry. This is the video. Again, the visco should be nicely present in the anterior chamber, and in this we use Sinsky hook. Again, the potential complication can be iridodialysis, as iris can be pinched between the nucleus and the Vectis, and more chance in brown and black cataracts. And if introducing Sinsky in already crowded AC, if the AC is not properly filled, can lead to descemet membrane detachment. Phaco fracture technique, the advantage of this technique is that since the nucleus is divided into two or smaller halves, so this can be performed with the smaller incision, thus inducing less surgical induced astigmatism. So either a bisector or a trisector can be used to fracture the nucleus. In this, the Vectis is only used and the nucleus is fractured just at the exit of tunnel, and again the longitudinal axis of nucleus is aligned perpendicular to the tunnel and delivered subsequently. This is a phaco fracture by a wire loop, also known as the snare loop. Again, the most important factor should be AC filled with visco, and the advantage of this technique is smaller tunnel and hence less surgical induced astigmatism. One other technique is Blumenthal technique. In this, after prolapsing the nucleus in anterior chamber, this uses anterior chamber maintainer. So then the irrigation is turned on, and the McPherson is used to depress the posterior scleral lip, and the nucleus is delivered nicely. So the advantage of this technique is that AC maintainer maintains the IOP, so eye remains more or less in physiological state, and it is safe techniques in all grades of cataract, and unlike with Vectis, it has lesser risk of iridodialysis. Again, this is the last method, the fish hook technique, also described in the literature. Uses 30 gauze band needle, has two angulation, terminal backward band and a lateral band. Advantage is that it occupies lesser volume in AC. So this is the method. The 30 gauge needle is introduced and helped in delivering of nucleus. This was demonstrated by Dr. Abhishek Anand in one of the articles. So in this only the linear capsulotomy is done, and once the superior pole of nucleus comes up rather than complete nucleus, so the fish hook needle is used and used to deliver the nucleus. So to conclude, I would say that there is no gold standard method of nucleus delivery, and it depends on surgeon's comfort and experience, the grade of nucleus and the sclerocorneal tunnel to perform the method. Thank you.
Yeah. Thank you, Dr. Akshat, for explaining all the techniques of the nucleus delivery. Here only two very important things to take care is about. One is your corneal endothelium, and down is your posterior capsule and your iris. Very nicely explained. That was good. And I liked about the take clinic points. We usually write take home points. It is a clinic or a home that is in your head. So if it is in your head, it will come in your hands to your clinic or a home. So we will take the discussion about this little later. I request our next topic is very innovative and the new technique, that is world's first non-invasive, non-pharmaceutical mydriasis enhancer. Actually, the present author is Dr. Raju Raut. For some reason, he is not able to attend. So I request Dr. Boramani to present on pupillo.
Yeah, good afternoon all. This is an invention by Dr. Rajiv Raut. Unfortunately, he is not able to attend this conference. So I am presenting on his behalf because I am also using this device. This is the first presentation in the world about a new device which sustains the pupillary mydriasis without using any invasive device and without using any pharmaceutical device. So let us see what is that. See, small pupil, generally the most of the complications happen because of the small pupil. You don't know where is the capsule axis, and many times you blindly keep aspirating and you'll end up in complications. So it's like driving a car in a very narrow passage. Many times our pupil is fully dilated, but during the surgery our tip touches or some instrument touches, and even without touching, pupil starts coming down. So we have to use a pharmaceutical agent like mixture of tropicacil, phenylephrine and anesthetic. So this is a device which we have found it sustains the pupillary mydriasis. It is not a solely mydriating, it is not a solely dilating device, it sustains. You have to dilate with the mydriatic eye drops and use this device, which is a non-invasive device, and then we have found that the pupillary dilation sustains very well, at least for 2 to 3 hours effect is there. So generally if the pupil is very good, the vision also is very good, but if the pupil is very bad, the vision also is not good. Even surgeon's vision is not hampered because of a bad pupil. Now this has involved 4 years of research and lot of expenses by Dr. Rajiv Raut, and he has used a computer HR video cam and LED computerized LED controller and done lot of animal experiments. He has found that somehow, I had visited his clinic also, red light in the OT area and preoperative area somehow keeps the pupil dilated. Even on internet also, then there are some papers, red light has got a lot of therapeutic effect, and one of it is pupillary dilatation. Second accidental finding is that the head nodding in Parkinsonism somehow is prevented if you use a red light in some red light bulb. That this is not mind finding, because he has operated 3-4 cases of Parkinsonism which have been refused in other OT because of continuous head nodding. This is another benefit of red light. So afterwards he has done lot of research exactly what should be the proportion of, it is not only the red light, it should be a good proportion of the red and blue light. You don't need a big red light bulb also. You raise a very small amount of red light and small amount of blue light. So after a lot of research, he has come to a conclusion of what should be the exact ratio between the red and blue, which keeps the pupil dilated. So this can enhance the effect of the mydriatics, tropicacil and phenylephrine, because life is the interplay of light and shadow. Now what is this device? This is a very small, less than a matchbox size device, which can be attached to a spectacle. So initially he used to attach it with the rubber rings, but after then he has put a metal plate on the side of the frame, and just with the magnetic effect the device get attached. You make the device on, there are 2 small dots through which the red and blue light comes, and the light doesn't fall on the pupil, it falls in the area up in front of the patient's vision. So I'll show you how. So this is a device. Initially used to attach it to a rubber band, and this device, the white switch is for making it on. So the mechanism of action, what he has found is it relaxes the sphincter of the pupil. It is not the regular mydriatic effect. The mydriatics, they mainly work on the peripheral muscles beyond the sphincter, but this beyond the collateral of pupil. So this is the inner area sphincter which is relaxed, and the mydriasis is enhanced with this device. So the relaxation is without rubs and stays remarkably for a longer period of to facilitate the surgery. It is markedly sustained dilatation. So this is a case of pseudo explanation wherein after the mydriatics use of mydriatics for 30 minutes, this device has been used, and this pupil also nicely dilates. Usually in pseudo explanation the pupil doesn't dilate properly because of the fibrosis of the sphincter, but somehow with the pupil it has been found that these cases also dilate very well. So because of the full dilatation, you can do proper cleaning of the entire capsule. Your visualization is better and your chances of complications are very less. So in conclusion, you have to use the Midriatic drops, eye drop or tropicacil, twice for roughly for say 30 minutes before putting on this device. Before taking the patient into the OT, you have to put this device on for about say 15 to 20 minutes and then take the patient in the OT. Now this is, he has given this research product to me. It has not come into the market. Already he has applied for the government license and he will be getting the license. I have done the cases. This is my study of 15 cases, cataract cases. So you can see on an average, say the dilatation is almost from 0.25 to some, in some cases it has dilated to 1 millimeter more diameter. So even 0.25, 0.5 is a great dilatation during surgery. So on an average, the dilatation is about say 0.65. In one case, it has not dilated absolutely. Somewhere the figure is there. The patient, that fourth number patient, it has not dilated. In some cases, I have achieved almost more than one diopter. That is the seventh case. So this is my video. Yeah, so see the size of the device, hold, and then you can see two holes, red and blue, just two dots, see, down. And when you make it on, it remains on for 15 minutes, automatically no need to, it cannot go off, it goes on its own. And with the magnetic device, it is attached to the spectacle frame on the side to be operated. So I used it for many cases now, and I am finding somehow that the mid-race is quite well achieved. So maybe we can take the questions at the end. Second incidental finding, just let me tell you that this device, if it is used, is bring down the intraocular pressure by 6 to 7 millimeters of mercury. So he is working on the proper proportion of the red and red and blue proper proportion. If it starts working say more than 9 to 10 millimeters of mercury, this may act as a replacement of anti-glaucoma drugs. But let us see. The mechanism of action is that, see, this light doesn't fall on the pupil, it falls in front of the area. You can, I have personally used, and you still feel something reddish or bluish in front of your eyes. So it stimulates the rod, something like night vision, and the eye thinks that there is a night, now night is happening, and that's why the pupil dilates. This remains sustained for 3-4 hours. 3-4 hours. No. For surgery is 15-20 minute job. अभी तक नहीं किया है. Let us see.
Well, this is something completely new, and we hope it works well and it is replicated at many more places.
That's really fascinating. So we move on to the next talk, and no talk is incomplete without the discussion of artificial intelligence. So I invite Dr. Jatinder Bali for his talk on application of AI in cataract surgery.
Good afternoon, ladies and gentlemen. At the outset, I want to thank Dr. Sahu, Dr. Boramani, the ISM SICS, and AIOS for giving me this opportunity to talk to all of you about the use of artificial intelligence in cataract surgery. I have no financial disclosures to make in this presentation. All of us know that artificial intelligence has been used in cataract surgery for screening and diagnosis. It has been used for IOL power calculations, for finding out which phase of the surgery is going on from recorded videos, and then now it is also possible to use that in real-time videos. It is also been used for prediction of the surgical procedure timings. So basically what it does is, from the videos, it calculated how much time you're taking for your rhexis, how much you're taking for your hydrodissection, hydrodelineation, and then it adds up all those individual timings for a given surgeon, and it works out a predictive time that you're going to take for a given case. Based on that, you can actually calculate for a given set of surgeons how many cases you would be able to perform in a given time schedule of whatever 8 hours, 10 hours that you have, that you're giving your OT out to them. So it is possible to optimize the operating theater workflows from that. It has also been used for visual access, opacification, prediction parameters. It has been used in pediatric cataracts for risk prediction, and it has also been used in visual access opacification in the follow-up of the pediatric cataracts. Now, all of it started off with, the first one was when we started looking at the slit lamp images, the fundus, and we tried to grade and classify the cataracts. Then we started looking at fundus images, and from the fundus images we tried to infer whether there's a cataract, or it's a referable cataract, it's an operable cataract or not. We've already talked about different phases of cataract surgery. What it initially did was it looked at the different instruments that were being used. From that, slowly it started predicting which phase of surgery based on that instrument, and then now it is possible to do it in real time procedures also. And what it did was it calculated that this is the time that a person is normally taking. If you were taking longer than that, then it started looking at complications and the complication modules to be kicked in. We've already said that it's talked about from the electronic health records. You look at the risk factors, you look at the demographic factors and other other risk factors, and from that you are able to actually predict what patients would require an early yagging. So far as the labeling of videos was concerned, initially it was limited to phacoemulsification surgery, and what is new now is that it has now become available for manual small incision cataract surgery also. Some of the authors in this paper they have been associated with us, and this was what was discussed in the last conference. If you remember that there's a lot of variability, but people are working on it. What else is new? In manual small incision cataract surgery, you see, when we were training people with simulators, the phaco modules all had this they had this facility that you could gauge yourself against your previous performances, and at the same time, if you had a peer group, the performance of the peer group could be evaluated against each other. That was what was not available with the MSICS simulator. Now that has also become available, and again, you see, why it makes a difference is India is the largest, is the country which does the largest number of M6, and we are also the cheapest source of data as well as data analytics. And some of the people on the project are sitting here also, I think. So that was that. And whenever we talk of IOL power calculations, basically we look at, it's a mathematical calculation. Between 22 to 24, almost all the formulas are going to perform adequately. It's only when you have very small or very large eyes that you need to tweak the parameters to understand, to get more predictive results. Basically, you want to reduce what we call the error term. The random error is what you're trying to reduce. Now, how does the random error? So basically, what you're trying to do is you're trying to predict what the effective lens position is going to be, where the lens is going to sit after you have completed the surgery, and that is dependent on a number of parameters. And when we started using larger number of parameters, we started getting more replicable more replicable results. But then you see what happens is if you reduce the number of parameters, your ability and your accuracy falls. If you increase the number of parameters, then beyond a particular level, once again your predictive ability and your accuracy is going to fall. And that sweet spot can be picked up when you are using machine learning. What are the different formulas being used? One is the new kid on the block is Carmona. We already have the Kane formula. In LADA Super, basically, you see what happens is whenever you're using regression analysis and you're just calculating a line, a regression line. It's a 2D analysis. Now, what happens when you are using, if you see, you have your length and you have your breadth, so you have only 2 dimensions and you can make a line. In ladders, what he is doing is he adds a third dimension to it. With mathematics, in physics, you can have only 3 dimensions, x, y, and z, right? In mathematics, you can increase the number of dimensions, it's up to you. Because dimension also, and then dimensionality can be reduced or it can be increased. So instead of a line, now you are calculating a plane. And where you get placed on the plane, you could be placed with this set of surgeons, with this set of surgeons. So what results you would be able to calculate after maybe 6 years or 7 years, the predictive analytics you were getting after 6 or 7 years of practice, now you will be getting it, you are getting it within the first 1 or 2 years. We have, the Pearl DGS, we have the Kane Carmona, the LADA Super we've already discussed. Of course, total keratometry is looking at, it's using the swept source, it's using swept source, and using total keratometry, even with the conventional formulas, gives us better results. And when you add it with the newer modalities, the newer formula, your predictive analytics is increasing. These are the different studies which have been done for screening and diagnosis of cataracts. These are for PCO risk reduction. This is for phase classification of cataract surgeries. And then we've already talked of, there are these people who are using different non-imaging risk factors from the history sheets using random forest and adaptive boosting algorithms. And then you can also decide which patients require a more aggressive follow-up using the CC Guardian, which uses a Bayesian algorithm there. And these are, all right, so basically this is all that artificial intelligence is being used for. To answer the question, is AI really going to take over and take away our jobs? The answer appears that it does not appear that the answer is going to be yes. The answer is no. The artificial intelligence is going to assist you in your cataract surgery. It still cannot convince the patient to lie still while you operate. Thank you so much.
Thank you, sir, for highlighting those different roles of AI in IOL power calculation and cataract surgery. So we move on to the last talk of this session, surgically induced astigmatism, a friend or foe of MSICS, by Dr. Narendra Singh Verma.
So thank you AIOC, ISMS Society, Dr. Boramani sir and Sahu sir for this opportunity. So I will discuss some burning factor, that SIA. So MSICS cause SIA. So whether SIA can be a friend or foe. So if your incision is customized and it is on a steep axis, it is a friend. For unplanned incision, it is a foe. So if you see, astigmatic correction during cataract surgery can be done by 2 ways: by taking incision on the steep axis and by implanting toric lens. So the incision based surgery, which include MSICS, is economical, safe, no contraindication, but the main issue is the predictability. The predictability issue arises because people who are doing phaco, in the phaco we are taking incision on steep axis, flat axis, oblique axis, so that we can't predict the SI in the phaco incisions. There is burn. When there is burn, there in spite of being flattening, there is stiffening. So they are saying that we can't predict the SIA, but you are telling about the incision which is taken in the phaco. We are talking about the cold surgery, which is like MSICS. When incision is taken on the steep axis, then it is predictable. I will explain with the very recent study and very genuine study. So SIA, to be a friend, you can correct astigmatism up to 0.5 diopter in 80% of cases if you will do 2 things. You customize the incision size. The incision should be customized. For that, you have to calculate the SIA, or you have to use some AI guided system. Will provide you on. You can operate on a mobile. So free, it will be available free. And then marking of the steep axis. So its marking should be, you have to eliminate head tilt and cyclotorsion error. So this is the study I was talking about. The 100 patients, they were operated, though phaco was done, but 3.5 millimeter phaco incision was extended and 3.5 millimeter OCCI was done. So this was, they have used as the good new Aladdin topographer, and what they have seen, that they calculate the SIA. So the SIA in this case, 3.5 millimeter OCCI was 1.28 diopter. So if you see, 80% of cases are lying in the range which is 0.5 diopter less and 0.5 diopter more than the 1.28 mean SIA. So if I am knowing my SIA of this incision is 1.28, in 80% of cases I can achieve astigmatism, post-operative astigmatism less than 0.5 diopter. So this is our SIA calculator. So you can access it on the mobile, and we have added some new feature. I will explain it. And it will provide you SIA by vector and polar method both, even centroid SIA. And one more extra feature, it will tell you that about the success in diopter. So if somebody will say SIA is 1.2 in 30 degrees, so you don't achieve anything, but it will tell how much success you achieve, how much diopter power is decreased, anterior keratometry power is decreased. It will also provide you. So the data sheet is very simple. It is in Excel format, and you have to fill only few datas, and only single data sheet for all type of 4 mm, 5 mm, 7 mm incision, even LRI, same data sheet. There is an option to select the size of incision and site of incision. So the software will only analyze these the data which are selected by you. So this is just a video. So we have also incorporated in this mobile app the toric MSICS nomogram, which is based on the Dr. Boramani sir's data. So what is basically we have compared, we have considered only, you see, the keratometry. So when keratometry is more, steep cornea, then SI will be more. Then we have incorporated white to white. When white to white is larger, SI will be less. And so depending on that superior to temporal. So we have made one basic nomogram which will guide you in this way. So it will give you that how much incision, in this case, how much incision if you will take. And this is our SI calculator. Data entry is simple, just like Excel format. You just enter the few data and it will that. Then the thing I was talking about, what modification we have done in our SI calculator. These are new feature we have added. So one is to calculate SI automatically. What happens that people they are who will take the preoperative keratometry, postoperative keratometry, who will enter the results. So we are having this incorporated in our topographer. Those who want to do a study, they will provide them a topographer. Serious study, those who want to do, then we will give them a topographer. And so you have to capture only two picture, topographic picture, preoperatively and after operation, postoperatively, 1 month after the surgery. The topographer will provide you the SIA. So this is the same thing. We have this nomogram in our topographer. So this is Dr. Boramani sir's nomogram. So when I went to this 5 mm. So the topographer will show me the results of my cases, 5 mm I have done. So how much was the SIA in my cases. So nomogram is there, basic nomogram. In addition, you will get whatever data you have saved in this topographer. So automatically it will calculate this. And for marking of the steep axis, we are having this module, image guided module, just like Callisto and Varion. So this is the image guided module which is compatible to all surgical microscope, which will provide you real time intraoperative alignment of toric lens, steep axis marking, incision size, all these things. So there is no lag in this. So this is our SIA calculator. You can access. It is compatible to iPhone and Android. You can enter this URL. It will work on all mobile, and we will add this new feature that you enter only pre-operative, post-operative keratometry. Automatically, it will tell in your old data how much was the SIA.
Yeah. Thank you, Dr. Narendra Singh Verma, for that.
Awesome.
Any questions to be asked? Discussant, Dr. Basin sir, you want to add any points?
I think the presenters were very good, and I just want to know about the availability of this these tools for how we can make this available and make it real.
So this SI calculator you can access on the mobile. So you can enter the data, it is accessible on a mobile or on a laptop. And a new feature we have added, you will have preoperative, postoperative keratometry. When you go to this nomogram, it will also tell your old result, how much was the SIA. So you can say that you can take any incision size.
Okay.
And the topographer, we will provide the topographer, those who want to do a study with those who want to do SICS, MSICS incision on the steep axis. So 2-3 topographer we will provide for the research purpose. It will be sellable after it is integrated with image guided. We will come with the whole machine.
So what is, how much time will?
The topographer, we have made topographer, it is for sale, but we will not sell topographer, we will sell it with image guided system less Callisto and Vario.
So it is in the process.
How much time?
But now we are planning to give the topographer to those 4-5 person who want to do study, because we want to prove that by MSICS incision you can correct the astigmatism, but the meticulous study is not there. So topographer pictures, they will provide us that, they are the just proof that our study was perfect, and we want to do some meticulous study.
No, but
So,
the image guided system,
Yeah.
how much time will it take?
sir, I have done last month one toric lens on this system, because we were coming with this and then we developed image guided system. It is developed in last 6 months.
We'll take the discussion at the coffee place, and we'll conclude this session. It was wonderful. I request all the panel